A very good afternoon to all our Physio TV viewers. I, Dr. Franny Nathani, Assistant Professor at Sancheti College of Physiotherapy, welcome you all to our today's webinar, which is on a very interesting topic, that is vestibular rehabilitation therapy, by our very own and a renowned speaker, Dr. Purva Tambe ma'am. This webinar is brought to you by Physio TV, for which we are extremely grateful to our founder president, Dr. K.H. Sancheti sir, our chairman, Dr. Parag Sancheti sir, and our executive director, Mrs. Manisha Sangvi ma'am. So before we begin with our session, I would like to introduce our panelist for the day. Our first honorable panelist is Dr. Poonam Gandhi ma'am. She's founder of Precision Physiotherapy Clinic. Ma'am has done her bachelor's in physiotherapy from Sancheti College of Physiotherapy. She has pursued her master's in adult neurosciences from School of Allied Health Sciences, Manipal. She has been working all kinds of neurological cases with special interest in stroke and vestibular rehabilitation. Ma'am has been focusing on ensuring to take latest research and techniques to the needy patients. We are pleased to have you here, ma'am. Our second honorable panelist is Dr. Manish Rai. Sir is currently assistant professor in neurophysiotherapy at Sancheti College of Physiotherapy. He has done his undergraduation from Chaitanya Medical Foundation's College of Physiotherapy, Chinchwad, and post-graduation in neurophysiotherapy from Sancheti College of Physiotherapy, Pune. He has special interest in spinal cord injury and vestibular rehabilitation. Sir is also certified NDT, CNDT. He is also certified aquatic therapist by ATNI and IATF. He is also certified IPNF level 1 and 2 therapist. He has also worked as a team physiotherapist for Indian National Paracyclic Team in 6th Asian Road Cycling Championship in 2017. Welcome, sir. I would like to request all the viewers, in cases of queries, you can put down in the comment section and it will be surely addressed at the end of our session. I now request our panelist, Dr. Manish Rai, to please introduce our today's speaker, Dr. Purva Tambe ma'am.
Thank you, Dr. Franny. Today we have our guest speaker, our own speaker, Dr. Purva Tambe ma'am. She is MPT in Musculoskeletal Sciences. She has done her master's from USA. Then she has experience of around 13 years. It's a vast experience. She has worked with multi-specialty hospitals like Dinanath Mangeshkar Hospital, Hardikar Hospital, and currently she is working in Sancheti Hospital. She is working specially as a vestibular therapist in Sancheti Hospital. She has special interest in soft tissue injuries and treating spine patients. So welcome, ma'am, and thank you for giving us so different and important therapy that we need to understand. Thank you so much for accepting our invitation, and we will start with the session.
Yeah, thank you, Manish, very much for introduction. Thank you, Dr. Franny, and thank you, Dr. Poonam, as well for joining me. Hello, everyone. So, without much ado, I will jump onto the vestibular rehabilitation therapy webinar today. To begin with, my idea is to, as all of us as therapists, my idea is to know the underpinnings of this subject, and I'm going to try to put them across to you so that in our clinical scenarios, we identify better that which are vestibular patients, which are not, which can be treated, whether they fall under the ambit of physical therapy or whether they should be referred out. So to begin with, I am expecting that all of you all have a fair idea of these points, and that's role of the vestibular system. What is vestibular rehabilitation therapy? What is VOR and its function? So VOR is vestibular ocular reflex. We will also talk about anatomy, pathways, and myriad connections vestibular vestibular nuclei have with other multiple centers in our central nervous system. We will talk a little bit about vestibular symptoms and types of disorders based on those symptoms. The last but not the least, we will also have a look at how do we go about history taking in vestibular dysfunctions. So to begin with, so vestibular system is basically one of the sensory systems, just like our vision and proprioception. The main function of vestibular system is that it maintains the spatial orientation and it helps in bringing about the stabilization of vision. Now, how exactly and how does it do? We will see it shortly. So now I'm going to talk about VOR, that is vestibular ocular reflex, which is the fundamental concept to understand the vestibular dysfunction or how or to know that how should we progress about the treatment of vestibular dysfunctions. So imagine I have purposely kept this picture here. Imagine that you are looking at an object which is right in front of you, and you want to move your head to either side. All of you all can do this so that you can better understand that how VOR works. But you want to keep focusing on the object of interest. Now, what happens that although your head is moving in opposite direction, in one direction, your eyes are moving in the opposite direction. And this particular way of stabilization of image of the object of interest on our retinas is brought about by the VOR reflex. That's vestibular ocular reflex. It's the basic it's the basic thing necessary for our normal vestibular system. Now, let's see what is vestibular. Yeah. So let's see a little bit about vestibular anatomy. As you all can see here, we can see the external ear, the middle ear, and the internal ear. We all can see there is a snail-like thing. I'm using a common man's language here, but I want you all to see the structure, which is amplified just next to the bigger picture here. And that is particularly a vestibular organ. Now, this vestibular organ is of immense importance. As you all can see that there are semicircular canals. Out of the one above is the anterior canal or the superior canal. There is posterior or also called as inferior semicircular canal, and there is horizontal semicircular canal. Also, beneath these canals, we can see I have written utricle and saccule. These are otolith organs. Now, there is also cochlea, as I'm just trying to point out here. That is an hearing organ. That is a hearing organ. I'm not going to talk much about it today. And very importantly, there is vestibulocochlear nerve, which is the eighth cranial nerve. Now, what's the role of this vestibular organ? So the the vestibular organ basically senses the movement of the head. In particular, semicircular canals detect the angular acceleration, whereas the otolith organs detect the linear acceleration. Now, what does that mean exactly? So when we are moving our heads, say we are doing, say, the horizontal movement, or we are pitching it forward, or we are tilting it to a side, that is the angular velocity, which is detected by the semicircular canals, and the otoliths, which detect the linear acceleration, that is the change of head movement with respect to the gravity. Now, as we all know that all these things are working always 24 by 7 every moment in tandem. And that's how we can make sense of our positions with respect to the environments and respond to balance ourselves in a better manner. So that's about the vestibular organ. Obviously, very importantly, we have vestibular cochlear nerve, which picks up these changes, which transduces which relays into the central vestibular system, and then the conscious perception of our position and motor responses are generated. So that's the whole vestibular system working in brief. Coming to the vestibular or oculomotor pathway, I have simplified and really dumbed it down. This pathway is not all that simple, but I want all of us to know this conceptually more. So as we all can see that it's a three neuronal reflex arc. So the periphery, that is the vestibular organ, sends the neurons to vestibular nuclei, which are located in the caudal medulla. That's the first neuron. Second neuron is from medulla to the abducens nerve, which is in the pons, and that is the second neuron. The third neuron is from pons to the ipsilateral lateral rectus muscle, that is abducens nerve, but it supplies the contralateral oculomotor neuron, from where the it relays or it supplies the medial rectus. Now, this particular pathway is of the horizontal canal, and more importantly, all of these neurons, they are congregated in medial longitudinal fasciculus. We will see its importance as we are moving on to the other slides. But not only this particular pathway is very important, because whenever we look anywhere, it is a conjugate movement. Our eyes move in the same direction. Our eyes do not move in two different directions. And that's why it is mandatory that our lateral rectors and medial rectors of each side, they work together to make sense to us and to have a stable vision. Along with that, there are other extraoculomotor neuron pathways, which are also in the medial longitudinal fasciculus. The medial longitudinal fasciculus also carries the descending medial vestibulospinal tract, and we will see its importance later on again. So let's talk about some secondary connections, and those are cervico-ocular reflex, optokinetic reflex. Now, these, the VOR, the COR, and the optokinetic reflex, all of these reflexes are extremely important to stabilize vision. And along with VOR, the other two mentioned reflexes are equally necessary for us to stabilize the images on our retina. And that's how we see things very clearly in a stable manner, so that our brain can analyze these images and make sense of it to us. Now, I would like to mention that cervico-ocular reflex is not very vastly studied here. Optokinetic reflex has a different path. It has visual pathway more. It's not related to, it does not take the vestibular nuclear pathway exactly. The cervico-ocular reflex, you can see it kicks in more in older people when their vestibular VOR is degenerating, or when you cannot really use VOR. We try to give strategies where they can use COR to again balance themselves. So coming to the other slide, so we have vestibular connections. As you can see that there is a meshwork of these vestibular connections. The vestibular nucleus complex being the central substrate here, that relays neurons to cerebellum, to hippocampus and amygdala, to cortex. VNC is also receiving the afferents from spinal and spinal spines, and it relays onto the oculomotor neurons as well. Each of these systems or neurons, they are particularly reflecting symptomatology. For example, if there is any disturbance in the vestibular nuclear complex and cerebellum pathway, we are going to see the undershooting or the overshooting saccades. With amygdala hippocampus, that is memory and learning, patients show a lot of emotional issues. Cortex is again very important for conscious perception, and oculomotor neurons, which obviously may bring about a dysfunction in the eye movements if vestibular nuclear complex pathway is affected. I have tried to just make it a little more dramatic here, because patients who we see in our department really feel a lot of these symptoms very overwhelmingly. So you can see that they have blurred vision, they have spinning, which is external. They also face imbalance. Sometimes they have headache, nausea, vomiting, and tinnitus. Uh, I would particularly like to mention that tinnitus is mostly related to Meniere's disease. We will see what that is later on. But the spinning, nausea, vomiting are particularly signs of the peripheral vestibular disorders. Um, so, based on these symptoms, we can classify the vestibular dysfunction as peripheral and central. When we classify, the idea is that as physiotherapists, what we can treat and what we cannot, or what we can cure and what we cannot. So, talking about peripheral vestibular disorders, let's talk about BPPV. BPPV is benign paroxysmal positional vertigo. So, as the name is quite self explanatory, the symptoms are brought on the change of position, it's sudden, and there is spinning, there is external spinning. People say that when they lie down or when they get up, they have rooms or fan, everything, things spinning around them. They also sense nausea and vomiting in the acute episode, which later on subsides. Vestibular hypofunction is follows after one has vestibular neuritis or labyrinthitis, which is inflammation of the labyrinth or vestibular cochlear nerve. And hypofunction is that means the vestibular nerve is not functioning at its optimum level. It sends aberrant signals to the vestibular apparatus, and that's how we see clinical signs such as nystagmus. Meniere's disease, although it is peripheral, it physiotherapists have very limited role in that. Meniere's disease is basically the symptoms are people have unilateral hearing loss, they have tinnitus, they have episodic vertigo, and that is something related with the increased endolymphatic pressure. And the most of the times the treatment is diet and medications, but which does not fall under our ambit. So, as therapists, we can help these patients when they have remissions of remission, when they are in the remission. But BPPV and vestibular hypofunction can very well be treated. We will see how what is the treatment and what are the exercise principles shortly later on. Talking about central vestibular dysfunctions, we have internuclear ophthalmoplegia. I would like to go to the previous slide here, wherein we had vestibulo-oculomotor pathway when we talk about internuclear ophthalmoplegia. So in multiple sclerosis, which is an inflammatory demyelinating condition, the medial longitudinal fasciculus, when that is demyelinated, when that is degenerated, we see abnormal eye movements because the pathways relaying onto the extraocular muscles are affected, and that's how that is called as internuclear ophthalmoplegia, which is seen in multiple sclerosis. And that's the significance. That's why it is important to know that what are the pathways, how are they relayed, so on and so. The central dysfunction is also seen, or it also reflects as cerebellar disorders or vestibular migraine. Again, Coming to our role with respect to the central dysfunction, that we cannot cure it, but the evidence says that people who have been treated with central vestibular dysfunctions do much better than people who are not. And again, the concept is neuronal plasticity. So there are different strategies to treat central dysfunctions. Coming to the history and triage. So whenever we have a patient in our OPD, it behooves us to find out that what has been their previous condition, if that is causing any vestibular episode, or it is a new fresh episode. And that's why history taking is very important. Triage basically helps us know that what examination we are likely to do and what we are likely to skip. So talking about pre-existing or comorbidities like medication, for example, patients might be on beta blockers and they have excessive hypotension and they can present with dizziness. There can be cardiac causes, psychiatric causes such as anxiety, almost precipitates dizziness, vertigo, and any condition. Now, temporality of the symptoms, whether it was episodic, whether it is acute or chronic. Obviously, because if it's episodic, we can think about Meniere's disease. Like I said, if it's acute, that can be either stroke or vestibular neuritis as well, or there can be chronic vestibular dysfunction. Along with these two things, we have triggers. Now, triggers, excuse me, in triggers, we have positional, so that indicates benign paroxysmal positional vertigo, head motion, visual, sound, Valsalva, and orthostatic. So I have not talked much about vestibular migraine, but usually people with vestibular migraine have severe headaches. Also, they have visual or sonic aura before they know that the episode is about to precipitate. And if there is an added symptom of headache, it can give a slight idea that okay, this patient might give us this cue about his condition. Orthostatic hypotension or Valsalva, where any pressure changes can compromise major arteries and lead to dizziness or vertigo. Now, so triage is very important before going on to clinical examination. Now let's talk a little bit about VRT, that's vestibular rehabilitation therapy. It is aimed at improving gaze stability, at improving postural stability. If if it is possible, we abolish vertiginous symptoms. If wherever possible, we try to mitigate them. Or the most importantly, after treating them as per their symptoms, it is very important for us to make sure that they live their normal life and we try to get them back on the track. So there are certain principles on which vestibular rehabilitation therapy is based. The principles are adaptation, habituation, substitution, and of course, balance training. Adaptation exercises are given when we want to re-establish the VOR. For example, in vestibular hypofunction, if it is a unilateral vestibular hypofunction, one side is not functioning well, the other vestibular nerve acts is the signal is taken as normal, and there is certain change, there is certain abnormality in the VOR. So we give exercises to re-establish this VOR, and which is quite possible because there is no central damage in this condition. Habituation is, let's say, People have motion sensitivity, so or and we want people to get habituated to particular motions or swift movements or fast movements, and we give them graded exercises with graded stimulus and exposure. So that is habituation. You habituate them to certain symptoms. Substitution exercises are given where we have no scope to improve or re-establish the VOR or in severe vestibular hypofunctions, particularly bilateral hypofunctions or any central vestibular disorders where we cannot re-establish VOR and we have to use substitution strategies such as cervico-ocular reflex or proprioception, or they rely more on vision, again, to maintain the balance. And obviously, balance training. Let's talk about BPPV because that has been the major chunk of this vestibular dysfunction seen in the OPDs. So BPPV is a mechanical condition. The calcium carbonate crystals, which are usually located in the otoliths, the calcium carbonate crystals, also called as otogonia, come undone and they start flowing into the semicircular canals where they influence the drag of the endolymphatic fluid. And that's how, whenever patient lies down or they get up, this drag abnormally stimulates the vestibular system and patients experience the symptoms of vertigo, external spinning, dizziness, etc. Now, what is so? There are tests which are like this hall pipe. Most of you all have heard about it. There are different tests to test different canals. Like this Dixhall pipe is for the posterior canal. The supine roll is for the horizontal canal, and the neck extension is for the anterior canal. So these tests confirm the presence of nystagmus. Many of the times, rather most of the times, patients who experience nystagmus actually experience spinning, which is due to this nystagmus, and these tests we call as positive. What we do is we do the repositioning maneuvers by which we take chances at putting these calcium crystals back into the otoliths, and the vertigo, the spinning, stops all at once. Now, let's talk a little bit about cervicogenic dizziness. Cervicogenic dizziness is a vague feeling of balance alteration and spatial orientation that is produced on by, by abnormal activity of the cervical afferents. I would like to mention that cervicogenic dizziness has to be taken with a pinch of salt. Many of the times, if we are not able to label or we are not able to diagnose, it is absolutely wrong to think them as cervicogenic dizziness and carry on with the treatment, because there are vestibular dysfunctions, especially like BPPV, which can be hidden. And if we give cervical exercises, that's just going to trigger these symptoms and bring on the severe episodes of vestibular dysfunction. So, in general, dizziness is more common in cervicogenic dizziness than spinning. As I said, it's a controversial entity. There are no specific tests with good sensitivity or specificity, and there is no clear pathological support. So that still remains a diagnosis of exclusion. I'm not trying to underplay the cervicogenic dizziness entity here, but I'm just wanting to say that it has to be weighed correctly when we see an individual patient, and the treatment can be progressed. Talking about cervicogenic dizziness, we can clearly see it in injuries post whiplash, which is a hyperextension flexion injury, or other cervical injuries, or even say one has any neck issues, any cervical issues, postural problems, definitely that's going to alter the spatial orientation, because we see that with rounded posture, one tends to poke their chin out, and the orientation and the proprioception automatically changes. As we know that the deep cervical flexors are extremely important, they're loaded with muscle spindles, and that becomes the basis of cervicogenic dizziness to treat. Talking, so again, when we have such entities, we may think about manual therapy to reduce muscle stiffness, to bring about a range of motion. We activating deep cervical flexors is very important, and releasing suboccipital muscles is equally mandated. It's very important. Coming to Frenzel's lenses. Now, these are the lenses which we use in the OPD setting to detect the nystagmus. So idea behind the Frenzel lens is that when people wear these lenses, the light is off. They cannot see anything, but that helps avoid the visual fixation. And that helps us better identify the magnitude and the direction of the nystagmus. So obviously the chances of diagnosis are fairer, and it influences outcome in a very positive manner. Especially we want to really discern that which canal, what could be the direction of the orthoconia flowing, etc. There are such, I would like to show you these videos. They are they're of the patients who I had treated, and my emphasis is I want all of us to know that how complicated, how fearful these patients become, even when they have this episode of BPPV. And just let's have a look at them in a short while. So.
हॅलो, मी स्मिता देसाई. मे 2019ला मला वर्टिगोचा मेजर अटॅक आला. म्हणजे मी सकाळी झोपेतनं उठायला गेले तर मला काही उठता येईना आणि मला पूर्णपणे बॅलन्स गेलेला होता. मी एका कुशीवरनं दुसऱ्या कुशीवरनं पण होऊन उठायचा प्रयत्न केला, पण मला काही जमेना. आणि मला असं वाटलं की आता मला काहीतरी मेजर झालेलं आहे म्हणून, आणि मी काय परत उठणार नाही आणि माझं आता लाईफ हे असंच असणार वाटतं. आणि मी खूप घाबरून गेले. मग मी डॉक्टर चेतन प्रधानांथ्रू डॉक्टर पूर्वा तांबे यांच्याकडे गेले. तर तेव्हा मी खूपच घाबरलेले होते. माझा कॉन्फिडन्स पूर्णपणे लूज झाला होता. मला वाटत नव्हतं की मी परत एकटी बाहेर जाऊ शकेन, येईन, गाड्या चालवेन, हे करेन. मला अगदी वाटलं होतं की आता संपलं सगळं माझं म्हणून. मग त्यांनी मला व्यवस्थित समजावून सांगितलं की मला काय झालं आहे, तुझा क्रिस्टल बाउन्स झालेला आहे, तुझा बॅलन्स त्यामुळे तुझा बॅलन्स होत नाही आहे, बॉडी इम्बॅलन्स होती आहे. मग त्याच्यासाठी आपल्याला एक ट्रीटमेंट करायला लागेल. मग त्यांनी ती मनोवर नावाची ट्रीटमेंट जी आहे त्यांनी ती माझ्यावर केली. एक 8-10 मिनिटाची, 7-8 मिनिटाची ती ट्रीटमेंट होती. आणि ती झाल्यानंतर मला खूप फ्रेश फील व्हायला लागलं आणि मी एकदम फ्रेश झाले, छान मस्त घरी आले. मी माझी सर्व कामं पूर्ववत करायला लागले. अगदी मला काही म्हणजे मला
So we just saw this video. My point was, the point I want to drag here, that whenever these people have vestibular symptoms, they really get scared. They don't know what's happening with them. They feel the whole world is turning around them. And we as therapists need to know that what could be the cause of it, or if it is peripheral, again central, if we can treat it, if we need to send them out. So let's also see another video.
2006 पासून मला व्हर्टिगोचा त्रास सुरू झाला. व्हर्टिगोचा त्रास सुरू झाला की मला छातीत धडधडायचं, नंतर हळूहळू मला अँझायटी आली. मला छोट्या छोट्या गोष्टी हॉस्पिटलमध्ये जायचं किंवा कुठे गावाला जायचं तरी मला, किंवा घरात कोणी आजारी पडलं तरी सुद्धा मला त्याची भीती वाटायची किंवा टेन्शन यायचं. कुठे वेळ पाहायची म्हटलं तरी मला टेन्शन यायचं. मग मला डोक्यात चक्कर करायला लागायची, छातीत धडधडायला लागायचं. इथे डॉक्टर पूर्वा मॅडमने मला संपूर्णपणे ट्रीटमेंट दिली. त्यांनी सुरुवातीला माझ्या त्या म्हणाल्या की प्रॉब्लेम असेल तर तो आपल्या टेस्टमध्ये दिसेल. ते व्यायाम केले आणि मला 15 दिवसात जवळजवळ 40% फरक पडला. नंतर मी परत एकदा त्यांच्याकडे 15 दिवसांनी आले. त्यांनी मला त्या व्यायामामध्ये काही मॉडिफिकेशन्स दिली, अजून काही त्यावेळी मला जवळजवळ 50 ते 60% आणि आज तर मी जेव्हा आले तेव्हा मला 90 ते 95% बरं वाटलं. त्यामुळे आपोआपच छाती धडधडणं माझं कमी झालंय, माझी अँझायटी कमी झालेली आहे, माझा थकवा कमी झालेला आहे. आणि कारण मला पूर्वी व्हर्टिगोचा त्रास झाला की मला थकायला खूप व्हायचं, माझा आता थकवा कमी झालेला आहे आणि त्यामुळे मी माझं नॉर्मल जीवन अतिशय आनंदाने आता जगू शकते.
So we just saw these two videos, and I want to bring to everybody's notice here that these individuals have really very complex symptoms. So it's only the symptom which is not, which should not be just taken care of. They should be looked at as individuals. Their psychological needs need to be understood. Their activities, their expectations from their own life, they need to be understood. And the treatment should be aimed as per their expectations. Also, we need to make sure that they understand what's happening with them, and we get that the whole approach, the holistic approach, really helps them get back to their normalcy. Now, coming So these people have many coexisting symptoms. They undergo physical and mental fatigue. They lead poor quality of life. What all they need is proper diagnosis, graded and appropriate stimulus, and understanding and support. So thank you, everyone. If you have any questions, we can discuss that.
Thank you so much, ma'am. It was a very informative session, and it is always an honor to hear from you. I now request our panelists to begin with our question and answer session.
Thank you, ma'am. Thank you so much. This was really, as Dr. Franny said, it was enlightening session. Ma'am, I have a query. How to differentiate between BPPV and central symptoms and cervicogenic symptoms? So sometimes what happens is we misdiagnose most of the times, and the treatment which is given goes wrong, and or it doesn't show any kind of effect. So if you can elaborate on that.
Sure. So to differentiate between BPPV and cervicogenic or central vestibular dysfunction, most importantly, as we just discussed, that BPPV comes or it's brought on by external spinning. People say that everything spins around me whenever I'm lying down, whenever I'm changing my position. We I'm only talking about the history part. The cervicogenic dizziness most can be attributed to having some element of neck pain, some element of posture, and obviously the central vestibular dysfunction might show more severe symptoms and signs such as loss of balance. Clinically, we can see Romberg's tests we can do, or there are other tests actually which I have not talked about, but there are saccades and smooth pursuits. So these, it's a combination of history and it's a combination of clinical examination. But from what patients tell us, that gives us a clue the way I just explained.
Okay. Thank you, ma'am.
Yeah.
Ma'am.
Hi. Yeah. Hi. This is Poonam.
Yes.
So, ma'am, actually, yeah, what you said is really right. That if treated properly, vestibular rehab can be really miraculous sometimes for the patient. And it is one of like the most rewarding things for a physiotherapist to actually have symptom relief or rehabilitation, which happens very faster compared to the other rehabilitation. If we talk about neuro rehab per se in general. So I had this question regarding how there is this new entity. I won't say new, but it is like, nowadays a lot of patients come up with this problem of triple PD. So it's like perceptual postural dizziness. So they have this continuous sensation of spinning, is which might be perceptual. We don't even know. Most of the tests are negative. So can you elaborate more on that?
Yeah. So it's persistent postural dizziness. That's what are you talking about? Can you hear me?
Yes, ma'am.
Yes,
Yes, ma'am.
yes, yes,
Yeah.
yes. Same
Yeah.
thing.
Yeah. So yes, obviously, see, this PPD is a very complex syndrome, I would say. Obviously, it is started with some episode of vestibular dysfunction. As we saw that there are various connections, the patients combine their previous knowledge and the present episode, and they try to restore the balance, but the motor movements or the strategies they use are they are wrong. These wrong strategies lead to wrong postures and wrong balance strategies, which induces more fear, and that forms a loop. Now, to break this loop, we need to first know whether there was any vestibular dysfunction. That should be the underlying vestibular dysfunction should be treated. They should be given assurance. Their balance strategies need to be corrected. And that's how we can treat these individuals. So obviously, again, there are, because it's a very individual experience, since although PPPD is a syndrome, it's a very individual experience. So we need to know that what strategies they are using, what were their vestibular deficits, and we can see what we can do about the treatment.
Yes,
Thank
ma'am.
you.
Yeah.
Uh, Ma'am, another question. What is the first thing or a first symptom we need to relieve in these kind of patient to improve their quality of life? So, as you have talked about, they have mental and physical fatigue also, and the they have quality of life is also reduced. So, basically, to improve, I have seen some patients who have stopped working because of this also.
Yes.
So how to improve, or how do we tackle, or what is the first symptom that we tackle?
I would say that first symptom we tackle should always be vertiginous symptom or vertigo or spinning.
Okay.
Unless we treat anything physically and
Mhm.
whatever is possible, we cannot expect patients to feel relieved about it.
Okay.
So, for example, BPPV, there are chances that we can eliminate vertigo. That has to be treated. Vestibular
Okay.
hypofunction, yes, it doesn't happen as magically as it happens with repositioning maneuvers. But yes, with exercises, we try to re-establish VOR, and they have a feeling of physical normalcy. Once that is brought into the treatment, they are relieved, they are assured, and then dealing with their cognitive and mental faculties becomes very easier. So I think it is that.
Okay. Ma'am, another question. How do you find the difference between actual testing it by physical tests and by the machine? So the machine you showed us right now,
Yes, yes,
and the actual test what we use for testing the vestibular system.
yeah.
How does it work? So how the diagnosis can be better with the machine and anything like that?
machine is basically these goggles. They don't allow individuals to fixate their vision.
Okay.
So we can, whatever the direction of nystagmus, whatever the abnormal movement of those eyes is seen as is with the help of those machines, the goggles, I mean.
Mhm.
Of course, to a naked eye, these movements can be detected, but if they are amplified, their magnitude, their direction is clearer to us, because any subtle change in the direction can indicate a different canal or a possibility of different mechanism in the same canal. So yes, anytime these goggles are better, yes,
So the reliability with the goggles for the diagnosis, better diagnosis.
yes, yes,
Yeah.
yes.
Thank you so much, ma'am. Thank you so much. I hand over the session to Dr. Franny.
Yeah.
Thank you so much, ma'am. I would once again like to thank you for such an informative and detailed session. You are really an amazing speaker, ma'am. I would also like to thank our panelists, Dr. Manish Rai and Dr. Poonam Gandhi, for your vital inputs. Our Physio TV team, Dr. Ashok Shah, Mr. Rahul Chaube, Dr. Apur Shimpi, Dr. Neeraj Athavle, Dr. Manish Rai, and all other members of Physio TV team. Lastly, I would like to thank all our viewers. Thank you so much for your constant support, expecting similar support for our upcoming webinars as well. So I, Dr. Franny Nathani, signing up for the day. Thank you.
Thank you. Thank you, everyone.
Thank you.